My name is Gerald Brandcaher from the Department of Plastic and Reconstructive Surgery at Johns Hopkins University School of Medicine. I was fortunate to be trained originally at Innsbruck, Austria, where I was a surgical resident and worked in transplant, and got engaged in the second double-hand transplant that was ever performed back in 2000 at our center. And I immediately got excited about this new field and decided at this moment that this is something I want to build my career on and try to have an impact and move forward a novel era in transplantation. Well, I think as you know, the first attempts to ever perform a human hand transplant were performed in 1964 in Ecuador. And the procedure at this early stages already was a surgical success, but unfortunately failed due to the requirement of sufficient immunosuppressive medication. And I think it was mainly the advancements in solid organ transplantation and improvements and developments in the design of novel immunosuppressive agents that has allowed us ultimately to perform the first hand transplant in this so-called modern era of immunosuppression in 1998 in Lyon, France, by a team led by Jean-Michel Dubenard. Well, I think the challenging performing double hand transplants are more from a technical perspective and the team approach and the surgical aspects related to the procedure rather than to immunological problems related to a double hand transplant as opposed to a single hand transplant. When we look at the data available from the world experience with upper extremity transplantation, there is actually no clear indication that a double hand transplant would require, for example, more anti-rejection medication or has a higher incidence of skin rejection episodes long term. Well, the most recent case here, which was the first done at the Johns Hopkins University School of Medicine, was performed on December 18th. It was a 13-hour procedure performed by a multidisciplinary team built up by plastic surgeons, orthopedic surgeons, and microsurgeons. The team was led by Dr. Andrew Lee, who is the chief of the Department of Plastic and Reconstructive Surgery at Johns Hopkins, and included a total of 16 surgeons from the Curtis National Hand Center, our colleagues and friends from Walter Reed, as well as surgeons from UCLA and UPMC. The surgical procedure is something that we rehearsed and designed prior to the actual transplant on multiple occasions. We had dedicated teams working together where everyone had a specialized role. We had team leaders on these individual parts. And for a double-arm transplant, it is actually 4 teams working simultaneously. 2 teams on each recipient arm, as well as 2 teams working simultaneously on the donor hands. It is a dissection of all the structures of the tendons, nerves, and vessels, and then the arms are brought over to the recipient side, and we consolidate the 4 teams into 2 teams as the transplant progresses. In addition to the recipient teams, there is also a donor team that is required for harvesting the donor hands. Our recipient had made tremendous progress. The wounds are healed. He has started already hand therapy. At this point, there have been no immunological complications, and he is progressing as planned. He is extremely determined, and I think he has a great future ahead of him. Well, the requirement of high-dose and multi-drug immunosuppression with all its related severe side effects really has hampered broader application of extremity transplantation for many years. This novel protocol that was designed by our group now really aims for the first time to be able to reduce the requirement of maintenance immunosuppression and to minimize the number and the levels of anti-rejection medications post-transplant. This protocol includes the use of bone marrow cells from the donor, and with this bone marrow cells from the donor, we try to create a very fine balance between immune cells from the donor and the recipient that can be maintained and allows for graft survival with very low levels of anti-rejection medication. So what this protocol that has been applied so far in a total of 10 upper extremity transplants performed in 6 patients was that we were able to reduce the overall number of medications from 3 different immunosuppressive drugs that are conventionally used in solid organ transplantation to 1 single agent at low levels in this patient. And by reducing this overall amount of immunosuppression, we really hope that we are able to balance risks and benefits of reconstructive transplantation procedure by minimizing the risks and toxicities of maintenance medication and favor all the obvious benefits such as a regain in function, independence, and obviously a significant improvement in quality of life. So the level of functional return is actually depending on the level of amputation and transplantation. And it is also depending on the pace and degree of nerve regeneration. This is a very slow process. The nerves that needs to regenerate from the recipient along the donor nerves to its end organs travels about 1 inch a month. So you can imagine with the level of amputation that it takes weeks, months, or even years in an arm transplant to regain both motor and sensory function. In particular, with regaining of intrinsic muscle function, we don't actually expect for intrinsic muscles to come back at a level above the elbow. However, what we have seen in all the patients worldwide so far, it is that they achieve a fairly high level of motor return, and all of those patients, importantly, regained at least protective sensation in their arms. What we have seen also from the patients transplanted previously, that the level of hand function that they can regain allows them to lead an independent, normal life. They can fulfill all daily activities that we take for granted. They can eat, they can feed themselves, they can hold a cup, they can drive, and they can go back to work and thereby regain their independence. There are obviously tremendous advances made in the field of regenerative medicine and tissue engineering. And I think there's various highly exciting avenues on the horizon. But truly also I think that we are far away from having those modalities being translated into the clinical scenario. I think there's a lot of hope and promise, but I see those modalities translated into a clinical scenario in the distant future at this time.